The next speaker is Dr. McKnight, who's currently working with my group in the Department of Sociology and Criminology on sexual health clinics and their practices. She's published and she's got a growing reputation in the AMR, and we look forward to hearing her talk.
Thank you, Catherine. Thank you so much. It's a pleasure being here. So this talk draws on ethnographic explorations of marginalization and efforts to reduce antimicrobial resistance within sexual healthcare clinics within 4 National Health Service trusts in England, NHS trusts. Catherine and I originally planned for this research to be an in-person ethnography that would take place within 2 different NHS trusts over the course of a few months, with a comparative leg in the United States. However, a week after commencing fieldwork, COVID-imposed restrictions put a stop to our efforts. Eventually, after numerous hurdles, the project was reimagined as primarily a virtual ethnography, with data collection taking place from March 2020 to March 2022, with many unavoidable stops and restarts throughout that process. Could I please have the next slide? Thank you. So in this talk, I'm going to draw on interviews with healthcare professionals within the sexual healthcare clinics, and in order to reflect upon some of the uncertainties that they spoke to us about during our observations and interviews. I'm more than happy to talk more about methods in the question and answer. Most of these interviews were virtual. We had clinical collaborators that helped us with recruitment within the clinics. And as you can see, it was incredibly difficult for us to recruit patients virtually in the way in which we were able to access them. So we're primarily focusing on staff and only staff in this talk. So we'll briefly outline 2 case studies that emerge in our research that explicate moments where health professionals express concern over the potentiality of anticipated, hidden, unknown, or unknowable organisms and events. Our thinking here is influenced by Brenman and Milne, who draw on John Law to query what would happen, quote, if we considered entities that were not just absent, but completely invisible or other. We're also encouraged by other researchers like Hannah Landecker, Patricia Kingori, and Aliana Kamenshikova, who just spoke, who explore in various ways what might be taking place in blind spots. So next slide, please. So as Hannah Landecker writes, if there is one thing that antimicrobial resistance is good for, it is that its study leads to the consistent upending of assumptions, both about microbes and about how completely humans understand or control them. What we see in overturning these certainties is that resistance has often flourished in blind spots generated by human categories of knowledge and action. It is therefore useful to think creatively about the very form of how we know about antibiotic resistance in society. So we take this on board, and we contend that in order to more appropriately know about antibiotic resistance in society and address AMR, and enable sexual health professionals to properly care for their patients, we must become better at acknowledging and contending with the blind spots and the significance of that which is absent or the not yet. So in order to do this, we draw on the astronomical concept of dark matter and energy and speculative intervening, as discussed by Wilkie and colleagues, to propose an intervention in the form of speculative visualizations of the unknown, as the unknown pertains to sexually transmitted organisms, as they might materialize and interact with bodies and antimicrobials over time, across and within and between various borders, barriers, and clinical spaces. So, next slide, please. So this is our first case study. It's a microbe called Mycoplasma genitalium, or MGen. It was first identified in 1980. Once a genetic assay had been developed, studies took place into prevalence, and it was found to have extremely high rates of resistance to common antibiotics, most likely as a result of being present while gonorrhea and chlamydia were treated in widespread screening programs. The common treatment for chlamydia and gonorrhea, azithromycin, has an unusually long half-life in which an initial high concentration is followed by much lower levels, allowing the organisms to select between themselves for those with some azithromycin resistance, and then let them multiply as the antibiotic concentrations decrease. Resistance testing using genetic technologies might seem to help disentangle the causes of the infection, but selective testing of orifices could lead to self-reinfection or reoccurrence, and not treating sexual partners may lead to reinfection with the same strain. The effects and implications of untreated MGen, especially anal-rectal MGen, are not known. Though there are now assays approved in both the EU and the US, there has been rather little screening and treatment, except in private practice, and public awareness of the organism is low. Prevalence and epidemiological studies in different locations and populations confirm that the organism is widespread and probably of long duration in humans. Despite lack of recognition, this organism is living with many of us unobserved. Moreover, widespread unavailability of resistance testing means that patients that are treated might have to adhere to lengthy treatment regimes with broad-spectrum antibiotics that might have serious side effects, including potentially chronic conditions such as nerve damage and inflammation of the lungs. This way of coming to know infections is problematic in that it does not allow for the unknown or the unknowable to be part of its enactment. Next slide, please. Like this, a consultant that we're calling Phyllis, not her real name, said, so we have access to testing, but we don't have access to the resistance test. In all other areas of medicine, if you have more than a 5% risk of antibiotic resistance, you shouldn't use that antibiotic. So we're in a situation where we're using a first-line antibiotic that we know in some areas has 60 or 70% resistance. So it goes against everything that you're taught about antibiotic stewardship. But the reason for doing that is that 30% will be sensitive, and then you can avoid using the second line, which is moxifloxacin, because moxifloxacin has significant side effects and risks. So you should really only use moxifloxacin if you know that you have to. So to my mind, it's an absolute no-brainer. And I'm so frustrated that we can't get this through because it's about money and it's not about good patient care and it's not about good antibiotic stewardship. It goes against everything, and yet we're having massive struggles to get it. Further to this history, MGen prompts uncomfortable questions in the clinics. What other hidden organisms might there be within patients that are being treated for recognized infections? And what might happen if these hidden or not yet there organisms gain resistance to common antibiotics as a result of the way in which recognized infections are treated? The next slide, please. So moving on to our second case study. Sexual health and HIV services in England offer a confidential service. Medical notes are not shared with other areas of the NHS. This is important, and while it is known to cause some complications within sexual health and HIV services, the risks are seen to outweigh the harm. Screening tests within sexual health services are offered based on a mixture of wider and national NHS and trust level policy decisions concerning financing and contracts, as well as understandings of symptoms of STIs, risk groups and populations, and the set of characteristics that are used to categorize people and their behaviors to fit into different groups. So here we can see how, in general, and this is not the case in all clinics, but if you are a cis woman, your vagina, urine and blood come under investigation, and so on. A patient's declared sexual history and symptoms, gender, and in some trusts, declared race and or ethnicity, or assumed race or ethnicity of both the patient and the patient's sexual partners, in addition to members of staff's interpretation of the patient's sexual history and presentation. These practices cause unease amongst staff in the clinics. Next slide, please. So as Faye said, we know that lots of young people are engaging in more anal sex. And I think we ask when we're taking sexual histories, I always ask people if people are, but I don't think that really translates into then also offering a rectal swab for some reason. It's just kind of been ingrained that in heterosexual people, you do a blood test and your urethral sample in men or a vaginal sample in women. And that just tends to translate that we're actually, if they're openly saying, yes, I had anal sex and it's without a condom, I think we probably should be offering those people rectal swabs as well. But the only time we do is if we have gonorrhea, because then we always do testing for all 3 sites. If we have confirmed gonorrhea, we should be doing a throat swab, a vaginal, urethral, and a rectal swab, regardless of sexuality, because we want the best chance of getting a culture to grow and to know if there is a resistance pattern. But in normal screening, we don't look for it. So here we question what a cis woman and men would have to do in order for their anuses to become orifices of interest within clinics that use this method of selection. If this is not done even after a patient claims to have unprotected anal sex. In other words, in these clinical settings, risky sex practices are essentially neutralized if and when the bodies that engage with them are not also understood of as always and already risky and at risk. Moreover, in this clinical scenario, certain anal rectal infections like gonorrhea have the potential to always remain hidden in heterosexual cis men and women. Thus, despite the fact that the sexual health clinic is a site wherein sexually transmissible infections and viruses are meant to be discovered and explored, cis heterosexuality may preclude further exploration. A particular concern is that mistreated and/or undertreated infections can allow antimicrobial resistance to emerge and spread and become effectively chronic for individuals. Next slide, please. So the data presented on this slide shows that there's a huge potential reservoir of infections. Practitioners in sexual healthcare services often spoke to us about hidden populations and their concern over the infections that may be lurking there. These populations are understood of as having difficulty accessing sexual health care services for various reasons. Here we suggest that another way of understanding hidden populations is by considering orifices that are never or rarely placed under investigation. Importantly, we're not claiming that anal, rectal, or asymptomatic STIs may or may not be found in this or that population. Instead, we'd like to draw out the uncertainty involved in attempts to establish where infections may be or not. Further to this, and importantly, we're not claiming that these unknowns are not known about in the clinic. The excerpts from our interviews show that they absolutely are. However, this knowledge does not then translate into the tools and resources that would enable the health practitioners to explore the known unknowns. So how can we contend with and think or hold space for these unknowns and what they might do in the future? This question is important, considering that the cure is known to have the potential to enable the materialization of incurable organisms. In an attempt to visualize and think about these dilemmas, we have found it useful to think with dark matter and energy to map the unknown and the potentiality of it of infections and AMR. So next slide, please. So this is a dark matter map. Physicists understand what we tend to think of as the ordinary stuff of the universe, the stuff we can see that is made of atoms, as making up a small percentage of what is known to be there. The rest, about 95%, is known as the dark universe, which is made of dark matter and dark energy. Dark matter is studied with the help of various computers, satellites, and modeling programs that explore and anticipate dark matter's effects on visible objects. So this image is from a computer simulation of a dark matter map that was used in the American Museum of Natural History's Hayden Planetarium Space Show entitled Dark Universe. The image is based on statistical matches to astronomical observations. The orange star-like bits represent baryonic matter, which are all objects that are made of normal atomic matter. The spider web-like material is dark matter. The surrounding grayness is dark energy, which is, a quote, a more uniform source of repulsive gravity that seems to now dominate the expansion of the entire universe, end quote. Next slide, please. So if we look out into the night sky and see blackness, it's not nothing. Instead, it is the stuff that enables what we can see to exist. More is known about what dark matter and energy are not than about what they are, and yet they're used to come to know baryonic matter and the expansion of the universe. We suggest that we must think of a way of contending with and keeping in mind that the space we're working with contains more that is not known than is known, and that our interaction and treatment of the known will have effect on the unknown, potentially making a post-antibiotic future a certainty. Therefore, we'd like to encourage a conversation that starts to assess the potential of speculative dark matter maps to intervene into the threat of AMR. Next slide, please. Chronic STIs and bodily boundaries. In so doing, we create an interdisciplinary visualization of post-antibiotic futures and the potentiality of unknown or unknowable organisms and events. And so we can begin to start mapping out what we know and the things we know to be unknowns. Thank you.